Good afternoon, and welcome to the American Lung Association's North Carolina Community Connections. Today's webinar is presented by Novant Health. My name is Lauren Love, and I'm the Executive Director of the American Lung Association in North Carolina. I'll be moderating and leading us through today's conversation. Also joining us is our North Carolina Development Coordinator, Sierra Springer. Sierra will be running the tech behind today's webinar. And on behalf of both of us and our North Carolina team, thank you for spending part of your day with us. Today's session is designed especially for people diagnosed with lung cancer, survivors, caregivers, and anyone wanting to better understand the journey from diagnosis through treatment and beyond. Our Community Connections series focuses on improving lung health and preventing lung disease, and we're honored to bring you experts who are committed to supporting patients every step of the way. Before we jump in, I want to acknowledge why this conversation matters so deeply in our state. Here in North Carolina, more than 9,000 North Carolinians are diagnosed with lung cancer every year. And unfortunately, around 17% of those diagnosed never receive treatment, often because of barriers to care, stigma, or late detection. However, we are seeing tremendous progress in screening, earlier diagnosis, biomarker testing, and new treatment options. And that's why conversations like today are so important. So a few housekeeping notes before we get started. So this webinar is being recorded and will be made available afterward for everyone who registered for this webinar through the website. You will receive a link to the webinar. The webinar will also be posted on the American Lung Association's national YouTube page. Throughout the webinar, please feel free to submit your questions through the Q&A button. We'll take as many as possible at the end of our session. We're going to do our best to keep today's presentation to no more than 30 minutes, but we will extend the webinar just 5 additional minutes to accommodate some more questions if needed. We are fortunate to have some amazing experts on today's panel to guide us through our conversation. Joining us today, we have Dr. Matthew Miles. Dr. Miles is a board-certified pulmonologist and critical care physician with more than 12 years of experience specializing in lung disease and lung cancer diagnostics. In October, he moved full-time to Novant's oncology department to help expedite lung cancer workups and diagnosis. He now focuses exclusively on patients with lung nodules, lung masses, and abnormal lymph nodes. He also leads diagnosis and staging using advanced bronchoscopy. Also joining us today is Nicole Mannion. Nicole is the nationwide director of lung cancer education for the American Lung Association. Nicole leads national strategies for screening, patient navigation, biomarker testing education, and support services across the full lung cancer continuum of care. Dr. Miles and Nicole, thank you so much for joining us today.
Thank you for having me.
Yes. Let us open the conversation today by discussing lung cancer screening. And Sierra, you're welcome to feature the panelists now on the webinar. So Dr. Miles, I'd love to start with you. So really, we'll start just at the most basics related to screening. So can you walk us through the current guidelines for lung cancer screening and how you determine who is eligible?
Yeah, so for the largest populations that are at high risk for lung cancer, helps us determine what patients we want to screen. And the U.S. Preventative Services Task Force is kind of one of the largest guidelines that are utilized. There are some others, but the vast majority are utilized by the U.S. Preventative Service Task Force. And the screening is covered by Medicare, Medicaid, and commercial insurance as well. And to help identify these high-risk individuals, we look at the patients that are at high risk for lung cancer, including patients that are ages 50 to 80, patients with a 20-pack year smoking history. And this is a way to kind of standardize smoking history. 20-pack years is equivalent to 1 pack per day for 20 years. Could also be somebody who's smoking 2 packs a day for 10 years or more, or half a pack a day for 40 years. And then also someone who is actively smoking or quit smoking within the past 15 years. because those individuals have been identified as the highest risk for lung cancer.
And for people who don't meet that screening criteria, which are many, is there any way to detect lung cancer earlier for them?
Absolutely. Yeah. So, as you mentioned, there are patients that unfortunately develop lung cancer that are lifelong non-smokers. Now approaching about 20% of lung cancer diagnoses are non-smokers. And that can happen because of genetic factors, family history, can happen related to radon exposure, secondhand smoke exposure, occupational exposures as well. Unfortunately, there's no standardization for screening protocols, but it is important if patients have any of those risk factors, including a first-degree relative with lung cancer, to discuss that with your primary care doctor or your pulmonologist to discuss potential screening options that could be done. Again, although it's not standardized, this is an area of research, and I suspect within the next few years there are going to be changes on this because 1 in 5 patients with lung cancer are non-smokers, and that number has been increasing.
Yes, we've been hearing about that a lot. Can you describe what the lung cancer screening process looks like? What can a patient expect, from the start of that appointment to through the end?
So when we're enrolling somebody in a screening process, we want to meet with them and have shared decision making. That can be through the primary care doctor, it can be through a pulmonologist, or it can be through a lung screening program to discuss, to one, make sure that they're eligible for the screening criteria. Like I said, it is covered by the Medicare, Medicaid, and commercial insurance as well. And then also, anytime we do a screening process, we're always going to, there's a chance of detecting false positives or false negatives. We may see things in the lungs that aren't necessarily cancer, but may need additional follow-up and workup. So it's important to have that discussion, to have the shared decision making before enrolling into a screening program. After a decision is made that the patient would like to enroll in a screening program and they meet the criteria, then they're scheduled for a low dose CT scan. When I say low dose, it's a lower radiation dose, about 1/10 of the dose of a regular CT scan to limit potential exposures to radiation, but it also helps get better visualization of the lungs and evaluate for potential lung cancers compared to a normal chest x-ray. Generally, the low-dose CT scan is done without contrast. So the good news, there's no IVs necessary, and a test, depending on the center, usually takes about 5 to 10 minutes. You're laying on a CT scan, happens pretty quickly, and then that's it. Usually, the radiologist will interpret that usually within a day or two, and that will go back to the ordering physician or APP.
We know that a lot of nodules show up by, I'll say, accident on scans done maybe in the ER or for some other reason. So, how do incidental lung nodule findings fit into your program at Novant, and who typically follows up when that nodule is found? Is it the ER team, the primary care provider, or is it someone else?
Kind of the previous motif of how lung nodules were managed were an emergency doctor would find a lung nodule and then send a note to the primary care doctor if the patient has one, or refer to a pulmonologist to evaluate it, which may or may not have a lot of experience with lung nodules or advanced diagnostic procedures, and that could potentially delay time to workup. In Novant, we recognized that, and we wanted to streamline the process to allow patients to have quick access to rapid lung nodule evaluation, especially for the high-risk nodules. And the goal is to identify the high-risk nodules for the patients and diagnose lung cancer sooner so that the patients will have better outcomes. The way that we do it is if a patient has an abnormal CT scan, of course, we have a dedicated clinic, the multidisciplinary lung nodule clinic that I see patients at. where the emergency doctor can directly refer to me. They also have a secure line that they can give us a phone call. But also the radiologist that interprets the CT scan, if there is a lung nodule that is highly suspicious, concerning, or a lung mass that really needs to be seen as soon as possible, they'll actually put in a little note that will flag in our system and actually populate on our list of CT scans to review. Every Monday, I meet with a multidisciplinary group, including a thoracic surgeon and an interventional radiologist, and all these high-risk nodules. We sit down and review and determine, hey, is this something that we can follow with imaging? Is it something that needs to be biopsied? And if so, how's the best way to biopsy it? And that way there's less runaround. We have evaluated the nodule in a multidisciplinary group, have a essentially have a plan for the patient, how to be most effective. So there's less runaround. We decrease the time to diagnosis. And if there is cancer there, that will ultimately decrease the time to treatment as well.
I know that a big part of your role involves diagnosis and staging, so especially using advanced bronchoscopy. And I think many patients may hear the word bronchoscopy and feel a little nervous about that. So, can you explain in simple terms what a bronchoscopy is and what patients can expect during the procedure?
Mhm. Yeah, so there's different types of bronchoscopies. Essentially, a bronchoscopy is a way to evaluate the airway with a camera. The traditional flexible bronchoscope is usually done under sedation, where the scope is inserted either through the nose or the mouth into the airway to take a look at the larger and secondary airways. As the lung nodule, or I'm sorry, as the airways go out further, they get smaller. And so the traditional flexible bronchoscope isn't able to go out that far, and that limits diagnostic testing and also limits being able to biopsy some of these smaller nodules. Because of that, we had to develop newer technologies, and this is going back several years. There's several different generations of navigation bronchoscopies, but now the most advanced system that we have is a robotic system, which is a catheter that is a lot smaller than a traditional bronchoscope. So the patient receives general anesthesia. They're asleep for the entire procedure, so they should not feel anything. The catheter is inserted into the airway, and using the information from the CT scan, we actually guide the catheter almost like a car GPS, following the tiny airways up to where the nodule is. And there can be some variation between what we see with the catheter and what we see where we expect the nodule to be. So we have some additional tools to confirm exactly where the nodule is in proximity to where we planned it out to be. One of those is what's called a radial endobronchial ultrasound, which is a small little catheter that uses an ultrasound to determine that we're right next to the nodule. If that's the case and we see the ultrasound very clearly that the nodule is right next to us, we'll put a small needle through the robotic catheter into the nodule and biopsy it all from the inside. So there's no incisions, in the chest. Everything's all done within inside the airway. Um, if the nodule is very small, if we're not seeing it with the ultrasound, we also have other tools. One particular is what's called a cone beam CT scan, where we'll actually do a CT scan in the room, which will help determine, take a picture exactly where the catheter is, where the nodule is, and it's connected to the robotic system, so it'll update where the nodule is. So we can make some adjustments on that, use the ultrasound, and then do the biopsy. And so generally we'll start off with a needle biopsy. I'll typically have a pathologist in the room to take a look at some of the slides to make sure that we're having adequate tissue for an appropriate diagnosis. And then after we do the needle samples, we'll do what's called a cryobiopsy. What that is a small catheter that gets really cold. It freezes the tissue around the lung nodule. We remove that, and that provides a larger piece of tissue for the pathologist to do genetic tests on, molecular studies, look for specific biomarkers that can help with management. Also, using the cryoprobe and freezing that tissue, it preserves the architecture, so it also helps the pathologist with diagnosis as well. After we do the cryobiopsies, we usually flush the area out with cold saline and remove that so they can spin down those cells and take a look at those cells as well. If there's a concern for an infection, we can also send that fluid to look for things like bacteria or funguses. After that, the robotic bronchoscope is removed from the airway. Also, it's not just important to diagnose the lung nodule. We also want to understand what stage it is, if it is cancerous. And the way that we do that is by inserting then removing the robotic scope and then also using what's called an endobronchial ultrasound scope, which is essentially a bronchoscope with an ultrasound on the end of it that is utilized in the main airways, like the trachea, the left main stem bronchus, and the right main stem bronchus. And the scope is pushed up against the air wall, the wall of the airway, and the ultrasound can see what's on the other side. So we can see where the lymph nodes are, and then through the scope, put the needle into the lymph nodes from the inside of the airway. So not only during the procedure can we diagnose the lung nodule, but we can also biopsy lymph nodes to help determine if it is cancer, what stage it is. All of that is done at the same time. After that part, the bronchoscope is removed. The patient is woken up from anesthesia, and we get a chest x-ray. As long as everything looks good, they go home the same day.
So, what does recovery typically look like afterwards? It sounds like so much is happening during that overall procedure, but how long should they expect to be recovering from that?
Yeah, so the procedure is generally well tolerated. Anytime there's a procedure where you're biopsying the lung, there's always a risk for complications. The risk for pneumothorax, which essentially is where we do a biopsy in the lung, and from that biopsy site, air may leak between the lung and the chest wall. That risk of that complication is about 5%, and that's why we get a chest X-ray at the end of the procedure. As long as that doesn't happen, and the x-ray looks good, patients feel well. Usually it takes them about a half an hour to wake up from anesthesia and they go home the same day. Because they receive general anesthesia similar to after a colonoscopy, they just have them relax the rest of the day, no driving, no working, anything like that, not making any big decisions. But most of my patients that are working actually go back to work the next day. They shouldn't have any chest pain, shouldn't have any trouble breathing. Some people may have a little bit of a sore throat from the tube that the anesthesiologist place, but otherwise it's a pretty well tolerated procedure.
Good to know. While I still have you, Dr. Miles, let's talk about treatment decision making. So, for someone with early stage lung cancer, how do you decide between surgery, radiation, or chemotherapy?
Yeah, so that's a good question. As far as the largest goal for all screening programs and also lung nodule programs is to diagnose cancer earlier, because the earlier we diagnose cancer, the better patients do. And really trying to have patients, if we can, diagnose them earlier in stage 1 or stage 2, having surgery for resection can really improve long-term survival and can be curative. So for the earlier stage cancers, we evaluate the patients if they are surgical candidates based on their function, based on their lung function. Specifically, we look at things like the FEV1, which is kind of a marker that we use to evaluate if there is presence of COPD and also their baseline lung function. We also use something called the diffusing capacity on the pulmonary function test to see if their lungs are healthy enough for surgery. And for patients with earlier stage lung cancer, if their lungs are healthy enough, physically, if they're healthy enough, then surgery is recommended. Now, for patients that are early stage who are not candidates, whether that's due to having significant emphysema or having other conditions that would preclude them, like severe heart failure, that it can be treated with radiation, specifically stereotactic beam radiation therapy, which is a type of radiation that concentrates to where this early stage lung cancer is. And that can also be very effective for patients. Generally speaking, surgery is preferred due to the longer term outcomes, but radiation is also an excellent treatment. Now, for patients that have multiple lymph node involvement or diagnosed at later stages, stage 3 or 4, unfortunately, about 40% of patients with lung cancer are diagnosed at stage 4. We're trying to help expand screening programs and detect cancer earlier to shift those stage 4s to, stage 1 and 2s if possible. But when we're talking about more extensive disease at later stages, it's really important to know not just what type of cancer they have, but the markers that could be targets for treatment. So we look for certain mutations, look for certain targets on the outside of the tumor cells. So there are certain medications that are designed to treat those types of tumor cells. So for patients that are stage 3 and 4, generally it'll be systemic therapy like chemotherapy, immunotherapy, a combination of those, and then plus or minus radiation. What's interesting and really, this is oncology and especially lung cancer treatments, are really changing very quickly. And just the way that we think about it, it was really, I'm just thinking even 5-10 years ago, if someone was stage 1 or 2, you do surgery. If they're stage 3 or 4, chemo and radiation. And now there are some studies that patients that are at stage 3 can actually be treated with surgery after having neoadjuvant therapy. So essentially, they would receive some therapy, some immunotherapy or chemotherapy, depending on the type of tumor that they have, to almost downgrade to shrink the tumor and to help downgrade it so they can be a potential surgical candidate. And there have, for non-small cell lung cancer, has been some excellent outcomes with that. What's interesting is there's also a recent study showing that for patients with stage 4 cancer, particularly they were looking at patients with EGFR mutations. It was in a North Star trial, actually used one of the targeted therapies for EGFR to treat that, shrink the tumor. And then for the patients that had less than 3 spots in their lungs, were then locally treated with radiation or surgery and actually had better outcomes. And their progression-free survival actually doubled from about 12 months, I think it was about 23 and a half months. So, we're kind of going from this motif where, you have a stage, you're stuck in that stage, you're getting that treatment and that's it, to now it's really kind of depending on the tumor, on the patient, and kind of how their story of cancer treatment is going. And that's why it's important to have a team of doctors that takes a multidisciplinary approach. So that way treatment can be reviewed to make sure that they're on, the optimal treatment.
Thank you so much, Dr. Miles. All those scientific advancements bring so much hope to this community that's impacted. We're going to move on to discuss the patient and caregiver experience. So Nicole, let's bring you in for this part. So what would you say are the 3 most important things that you want patients and caregivers to know when they're navigating a lung cancer diagnosis?
Yeah, and I first want to say just thanks to Dr. Miles. That was such great comprehensive information that is really, really helpful just to hear and kind of sets the stage for sharing more resources and providing the information I'm going to share. But I would definitely say the first thing to reiterate to patients navigating this diagnosis process is that they're not alone. The lung cancer diagnosis can feel extremely overwhelming and isolating, especially in those first few days where it's really more of an emotional emergency for the individual going through those further testing procedures, not knowing what's happening. There's a lot of panic that can set in. But there are teams, resources, and patient navigators who can really function as guardian angels during this time and can help with understanding tests, treatment options, financial concerns, and emotional needs. The second most important thing that I would say, Dr. Miles, you touched on this, is definitely biomarker testing and understanding the diagnostic procedures and how important understanding exactly what those procedures are is. Understanding your tumor type and getting those comprehensive biomarker tests done can make a complete difference in the type of treatment and care that you receive. If you are eligible for a targeted therapy as a result of the comprehensive biomarker testing, the downtime from that as you're going through treatment is so much less than traditional chemotherapy or radiation. There's less side effects. It's less time consuming. And so it can change the landscape of the care continuum for an individual going through that diagnostic process. And with that, it's important to ask the right questions. Has comprehensive biomarker testing been done? And do you have all of the information that you need about my cancer to make the most informed decision for my treatment? And lastly, I would just say the care team is so important. Dr. Miles touched on the multidisciplinary care aspect. And I think that that's something that's now growing in popularity and being more normalized. But sometimes, we might not have the clearest communication. And we do know that clear communication is going to lead to better care, and that more care physicians in the same room are going to provide more information that's more comprehensive and leads to better treatment outcomes. So it's really important to make sure that you're comfortable with the care team, and that you have the right questions to ask, and that you feel comfortable asking those whenever possible to stay confident and informed throughout the cancer journey.
Nicole, I know that the American Lung Association offers a tremendous number of resources. So let's talk through just some of those. We certainly don't have enough time to talk through all of them, but what do you, if you had to pinpoint a few, what would you like to highlight it's the best way to offer help to patients to better understand their diagnosis and treatment options?
Yeah, absolutely. I would say the first resource point is definitely our website, and I'll send some follow-up resources after today's webinar. But our treatment and diagnosis pages are very up to date and have a ton of information there. We really work to make sure that the Lung Association web pages can focus as sort of a one-stop shop. So you're not spending a lot of your time going to different organization web pages or doom scrolling or trying to figure out who do I trust with what information? And there's just so much information that's circulating out there from different sources. So we offer, live webinars. We have plenty of one-pagers, toolkits, PDFs, worksheets that can help guide treatment and can help with organization throughout the treatment and diagnostic pathway. We recently completed an educational webinar titled From Detection to Decision, Navigating the Lung Cancer Diagnostic Pathway, and that featured a thoracic oncologist and patient advocate. But then we also have flip charts that walk you through diagnostic procedures so that you can understand with clear, easy, relatable information and language and take that back into your own learning. We've got online training modules such as Lung Cancer Basics and our support group facilitator trainings that can really provide that in-depth overview of lung cancer. And that covers everything from screening through survivorship. So I definitely promote our kind of worksheets, live webinars, and then our online training modules as well. But I really also want to highlight our Lung Health Navigators, who are a great resource to get more information and support. And that's with a trained nurse navigator who is well-versed on the lung cancer care continuum and specializes in lung cancer education and support. And they can provide that one-on-one education and help with locating appointments, follow-ups, and screenings.
And we know that caregivers often shoulder so much of the emotional and logistical load of a lung cancer diagnosis. So what support does the American Lung Association offer specifically for caregivers?
We have our patient and caregiver network. I would say that's a great place to start. But then we also have a lung cancer survivors online support community on Inspire, and that's free. So that's an online support webpage there. But on the patient and caregiver connection, we do have community connections for lung cancer patients and caregivers, and that's held on every other Tuesday of the month. So that's a great chance to get that one-on-one time with fellow lung cancer patients and caregivers, but then also to connect with the nurse navigator on a particular lung cancer topic. So I would say that's another great resource as well. But then storytelling is a really powerful way to receive that extra emotional and comprehensive, compassionate support from the community. Sometimes writing can be therapeutic, and sharing those stories through Lung Force can help bring much needed attention to the disease from the caregiver perspective. And then we also have our Lung Force movement. So that's another one to keep anyone to raise awareness really for anyone going through the lung cancer diagnosis, and to honor their loved ones as they go through this process. And then there's also grief support groups and resources at Cancer Care. And we have a mentorship partnership with Immerman's Angels, where you can connect with someone going through a similar experience and sort of become like a pen pal, but really collaborate on that shared experience together.
You touched on this earlier. We know the internet can be a very useful tool, and we also know that there can be a lot of misinformation on there. So, how would you recommend that patients and caregivers find credible information and, most importantly, avoid misinformation online?
Yeah, I think finding trustworthy lung cancer information can be challenging, just because we really need to call attention and acknowledge the amount of stigma that is out there in lung cancer communications. And sometimes it can be somewhat of a black hole that has a lot of misinformation on the internet. But there are a lot of simple ways to really stay safe. I think patients and caregivers should rely on finding reputable sources like major cancer centers, national health organizations, such as the Lung Association, obviously, and then the government health sites like the CDC and NIH, who are doing a lot of the research on the approved treatments and screening, and are really providing a lot of the nationwide expert resources that are out there. I would say to really try to avoid social media posts or personal blogs that make big promises or seem to promote miracle cures. You want to look for scientific evidence that really backs any type of bias or opinion and is updated regularly, but also avoids overly emotional or fear-based and stigmatizing language. So when in doubt, you want to bring what you find, if there is anything that seems contradicting, to your care team and ask them to help you sort out the facts and any misinformation. And I think that that's where the value of having a really strong, supportive healthcare team and those patient navigators can help people going through the diagnostic process find reliable information and resource, and stay away from that misleading or harmful content.
Thank you, Nicole. This has been such a great discussion. I want to see if we have any questions submitted. Hold on just one moment here. Dr. Miles, I'll direct this one to you. For patients who feel nervous about lung cancer screening or follow-up scans, what guidance do you typically offer to help ease those concerns?
Yeah, so lung cancer screening is something that is very important, because if heaven forbid, if somebody has lung cancer or something that's concerning, that it could be found earlier. And the earlier that it's found, patients will have better outcomes and accessibility to more treatments as well. Certainly, anytime there's a test done, there's a lot of there can be a lot of anxiety with that. And I think making sure that you have a good support structure for that, also being able to talk with, the provider that ordered the test, about some of those, so that way, I think the more information you have about screening, why we're screening, and being empowered by that can help ease some of that. Certainly it's there is always going to be some concern, especially if we do find a nodule. That doesn't necessarily mean that it's cancerous, but what it does mean is, that we have something that we may just need to keep an eye on. Just to make sure it doesn't change. And I think being proactive for this is really going to be in the best for the patient. But ultimately, having information and a good support team can help ease some of that anxiety and some of those fears.
Thank you. Nicole, this will be our final question just from a time standpoint. Nicole, what would you say the most common barrier is that people face when trying to navigate care, and how would you recommend they overcome that?
It's hard to select just one, but I would say the most common barrier, and Dr. Miles touched on this too, is definitely the delays in diagnosis and late stage diagnosis, especially if a patient doesn't have access to a screening or the ability to receive a lung cancer screening due to lack of insurance or underinsurance. And we see a lot of this pop up, especially with insurance barriers, socioeconomic status, and then rural health populations just facing transportation issues or the lack of access to care from a geographic standpoint. But then secondly, there's the emotional weight of fear and stigma that comes with lung cancer, kind of piggybacking on that so much as that if an individual knows that they're eligible and they do have that history of smoking, there's the hesitancy to get screened, but then the added fear and stigma behind the weight of that diagnosis likely coming back with a positive finding, or that scan coming back with a positive finding or a suspicious finding, and then the double down or the double bind of having to follow through with treatment after if they can't afford it and they can't make it to treatment appointments and all of that. So it's a very comprehensive picture. It's a big picture issue when we look at barriers, and I think there's a lot of different components that come into play with it. But I would definitely say the delays in diagnosis and the stigma that kind of contributes to those delays and the fear surrounding that all kind of pile into one big problem.
Thank you, Nicole. Sierra, if you could share our resource page. Before we conclude this session, we just want to share some important resources regarding lung cancer. The American Lung Association is committed to supporting those impacted by lung cancer, and we're so proud to partner with organizations like Novant Health to improve lung cancer survival rates throughout North Carolina. So for more information, I'd highly recommend visiting the websites listed on your screen. We will include this information in a follow-up email, in addition to some additional resources that Nicole shared. This has been a great conversation. Thank you all so much for attending today's Community Connections. I hope that you found it informative. We are so grateful for our amazing panelists. Thank you, Dr. Miles and Nicole, for your time, your insight, and your service. Thank you again, and I hope that you all have a wonderful day.